Hi, good evening. Am I audible?
Yes, ma'am.
Great. So, hello, good evening. I'm Dr. Shrestha, and I will be taking prosthodontics. So, as you know, prosto is basically divided into three sections, primarily three sections, but we have more of it though. So, you will be dealing it under complete dentures, fixed partial dentures, and removable partial dentures. Now, the thing about complete dentures and FPDs, most of the cases, it will be much more relatable to you, easier for you to pick up because you are doing it more commonly in your clinical practice. Even when you're students, from your third year, you are doing both of these. But when it comes to RPD, the regular RPD that we do in colleges or clinics is basically a interim prosthesis or a temporary prosthesis. The actual one is a cast partial prosthesis, which we are not dealing with initially. So that's the only thing which will have a lot more of components that you'll have to actually study and take it back. Okay. So as we do the questions today, what I repeatedly saw is that most of the question papers have repeated questions from prosthetics. They have a standard set of questions which are asked repeatedly on and off. Okay. And in that, most weightage goes definitely to complete dentures. Most questions come from complete dentures, then from RPD, and then from FPD. In FPD, in fact, even the questions that are asked are very, very similar and almost the same, right? They do have, situational questions or case-based questions for RPD, FPD, and complete dentures also. So starting with the questions, which of the following major connectors is both rigid and not bulky while not covering the entire palate? U-shaped palatal connector, anteroposterior palatal bar or strap, single palatal bar, or continuous palatal strap. So in this, of course, your answer will be your anteroposterior palatal bar or strap. Here, it is both rigid, not as bulky as a complete palatal, and then it does not cover the entire palate also. You have a bar in the anterior portion and in the posterior portion, and it is hollow in the center. Now, in a patient, okay, where the mandibular posterior teeth are missing and is planned for a removable partial denture, but has periodontally compromised lower anterior teeth, what will be the choice of a major connector? So the situation is there is posterior teeth missing in the mandible. RPDs, of course, planned, but the anterior teeth are periodontally compromised. So here, the choice of major connector is going to be a lingual plate, okay, not a lingual bar or label bar or sublingual bar. Why? Because a lingual plate can give two advantages. One is it will give a splinting action for the tooth so that it holds the remaining anterior tooth in place. Okay. And the second thing is that since there is less support from the tooth, you get extra retention from this for retaining your RPD. So it is a lingual plate. The distance from the center of the incisive papilla to the edge of the maxillary incisor is typically, that is, distance from the incisive papilla, center of the incisive papilla to the edge of the maxillary center incisor. Now, in this case, what we usually have to think about is that we can divide the incisive papilla into three different portions. Okay, the tip, the center, and the end. Okay, where you have a teardrop shape. The thinnest portion is the tip, then the center, and the bulkiest portion is the end. Now, the distance of your central incisor till the center is going to be 8 to 10 millimeters. Okay. If they ask you what is the distance of the incisive papilla, that is of the incisive papilla to the maxillary incisor, you can always mention the 6 to 8, because from the maxillary incisor till the incisive papilla, that is the beginning of the incisive papilla, is 6 to 8 millimeters. Till the center of the incisive papilla is going to be 8 to 10 millimeters. So please do read the question carefully before you go into the answer. What is the term for the triangular gap which is observed between the upper and lower dental arches during the forward jaw movement? So when you bring your lower jaw in front, that is in protrusion, when you glide it along your lower anteriors and bring it into protrusion, you will feel there is a gap between your posterior teeth. What is that triangular gap called as? It is called as Christensen's phenomenon. Okay. Now, what is it in balanced occlusion? A balanced occlusion, the definition states that it is the bilateral, simultaneous, antero-posterior relationship of the maxillary and mandibular teeth in centric and eccentric position. According to definition of balanced occlusion, it is a bilateral, that is on both sides, simultaneous at the same time. So there is contact of on both sides at the same time in antero-posterior direction, that is in the anteriors and in the posteriors, in centric and eccentric position, that is when in centric occlusion and when in eccentric position. What are the eccentric positions? You have protrusive, you have right lateral, and you have left lateral. These three positions are the eccentric position. Any other position other than your centric relation is your eccentric position. So you have bilateral, simultaneous antero-posterior relation of the maxillary and mandibular teeth in centric and eccentric position. So you have contact of teeth on all these positions. So in balanced occlusion, Christensen's phenomenon is completely eliminated. That is why it is called as a balanced occlusion. That is when you bring the denture in front to the right lateral, left lateral, any position, there is contact in all the three areas, right posterior, anterior, and the left posterior. There is a contact in all the sides. That is the concept of balanced occlusion. So always remember your Christensen's phenomenon is eliminated in your balanced occlusion. Then you have Silverman's closest speaking space, the S word. Okay, when you say S, the space which is formed is your Silverman's closest speaking space. Bennett shift again. Bennett shift determines the angulation between your condyle and the condylar head, the angle at which the transition happens when in lateral excursions. What is the advantage of giving a subgingival finish line? Superior aesthetics, easier to record impression, accurate fit of the prosthesis, or maintenance of good oral health. It is difficult to maintain a good oral health with a subgingival finish line. Very clear. Easy to record impression, not really. You need excessive gingival retraction to clearly record your subgingival finish line. Accurate fit of the prosthesis, you cannot really determine that if it is accurately fit until you have further investigative procedures. But it can definitely give better aesthetics, especially in the anterior regions. There will not be a clear demarcation or a margin between the tooth and your crown. So it is much more aesthetic in your anterior regions. What is masseteric notch? Masseteric notch is formed due to the action of masseter on the buccinator. Where is ovate pontic indicated? Indication for ovate pontic. Ovate pontic is always indicated when asked to give a pontic in a freshly extracted socket. It will look like the pontic is actually erupted out of the gums that is why it is given in a freshly extracted socket. This can be the same type of question can be asked in a different way. That is, a patient has undergone an extraction of the maxillary central incisor and wants to replace the missing tooth. Which type of ponting is ideal to give? In this case, because it is a maxillary central incisor, freshly extracted, it is always better that you choose a ovate pontic. An edentulous patient was given a denture with anterior and posterior palatal strap. Where should the posterior palatal strap be placed? At the junction of the hard and soft palate, mostly on the soft palate, entirely on the hard palate, or mostly on the hard palate. When you're talking about a metal strap, when a metal denture, never cross the metallic portion over to the soft palate, never to the movable area. That can cause loss of retention. So always keep the posterior palatal strap short and keep it entirely on the hard palate. The maximum till the junction, that is your PPS area, is touched only by acrylic when you give it in a complete denture. That's an entirely edentulous patient that you've given a metal-based denture. Okay, so never extend the palatal strap up to the PPS area. So it is placed entirely on the hard palate. Double processing method is used for large ocular prosthesis, impressions for implants, curing of complete dentures, or for making impressions. Very clear, it is for curing of complete dentures. The distobuccal flange of mandible is shaped by the distobuccal flange of the mandible is shaped by the action of masseter on buccinator. Which procedure is being done in the image? This is the image given. What is the procedure that is being done in this image? The options given are intraoral tracing to find the centric relation, Gothic arch tracing for centric relation, kinematic facebow transfer, arbitrary facebow transfer. This procedure is called as your Gothic arch tracing for centric relation. This is your extraoral Gothic arch tracing which is done. Okay. Now, how would an intraoral tracing look like? You cannot see it in an image like this because it will be attached to the occlusal rims and it will be inside the patient's mouth. You can only see it once you take out the rims from the patient's mouth and view it outside. Okay. Here in the upper tracer, you have a styli and the lower one has a metal plate. So you apply a white material. We usually use zinc oxide powder mixed with saline. Just mix it and apply a very thin layer onto this plate. The patient has kept both the tracers, that is the upper styli and the lower tracer, is attached to the occlusal rim, and the patient is guided into each position. That is first in the centric position. Then he is asked to make a protrusive movement. So you have one point. Then when it goes in the front, the point comes behind. Back to centric, right lateral, left lateral. Okay, so you get a correct arrow-shaped tracing. That is called as a Gothic arch tracing. In the prosthesis which is shown, what is the contraindication of the prosthesis shown in the figure? So this is a resin-modified bridge, like a Maryland, which is being given for, replacement of a single tooth. In this case, a short span bridge, it is indicated. Single posterior tooth restoration, though it is not much advised, it can be given. Like, for example, you have a premolar to replace, you can give. Though it is not much advised because it might not be able to take up too much of load. For periodontal splinting, the wings can act as a splint for your adjacent periodontally weak tooth. Imagine you have periodontally weak tooth and you cannot do an FPD in that situation. So this is a much more economically better option. But this cannot be given in case of a deep bite. Why? Because in case of a deep bite, there is always a chance that this will get dislodged every now and then because excessive force on the tooth, and it will keep getting dislodged from the position. What is Anti's law related to? What does Anti's law state? Simple. Anti's law states that the pericemmental area of the teeth to be replaced should be equal to or more than that of the pericemmental area of the adjacent abutment tooth. So depending on this, if you have a single premolar, you can take 2 abutments. That would be sufficient. But imagine you have 3 tooth, that is 1 premolar and 2 molars to be replaced. You cannot just take abutment of 1 premolar, first premolar, and 1 third molar. Why? Because the pericemmental area of first premolar and third molar will be lesser than that of the combined pericemmental area of your second premolar, first molar, and your second molar. Okay. So the combined pericemmental area of the pontic to be replaced, that is a missing tooth to be replaced, should be lesser than the abutment pericemmental area. So this is basically related to selection of the abutment. Pericemmental area is replaced and missing teeth. If you did not, when you have 2 options now, selection of abutment, yes, that is also what Anti's law is related to. But primarily, it is talking about the pericemmental area, and that is why the first one is the answer. If the first was not there, you could have always put it up as selection of abutment, because that is what we use Anti's law for. Coming to female patient who has missing left lateral incisor, canine, and first premolar. What is the most appropriate treatment in this case? Lateral incisor, canine, and first premolar is missing. Let's come to the options. Cantilever on second premolar. No, not possible. You cannot cantilever 3 units onto a second premolar. So that's not the answer. Cantilever on right lateral incisor. Doesn't make sense at all. Maybe they meant to ask about right central incisor. Again, it is not possible. You have an option of an FPD where you have the central incisor, then you take the second premolar and first molar. Then you have an RPD. Now coming to the anteriors, the most, so here in this, you can choose from FPD or RPD. The most ideal appropriate treatment would be to give a FPD. Why? Because it's a female patient, 3 teeth are missing. when you have good support from the abutment, you can always give for an FPD. Anteriorly, RPDs can be disturbing and less aesthetic also. Because here, definitely the clasp is going to come on the central incisor. So that is why FPD would be the better option. The most common cause of failure for an implant retained prosthesis, the most common cause. All these causes, that is screw loosening, implant mobility, peri-implantitis, prosthetic failure, all of these are reasons of implant failures. Okay. But the most common cause is usually a screw loosening. If you have a prosthetic failure, the first thing it exhibits as is screw loosening. Okay. Peri-implantitis, of course, you have the whole implant which is loosened out. Implant mobility and peri-implantitis is correlated. If you have a faulty occlusion, the screw will loosen first. If you have a cantilevering, the screw will loosen. So the most common cause of a failure is your screw loosening. I think that was a repeated question. Yeah. In this image which is shown, what is a technique for implants which is used here? So in this, if you can see, in the first picture, you have the whole tooth. Then the crown is cut off. In the third picture, the root is sectioned. In the fourth picture down, you can see the inner portion, that is the palatal portion of the sectioned root is being removed. Okay. And in the fourth, actually the picture, they have not mentioned something. In the last picture, they have shown there is a thin wall of root which is remaining and then an implant is placed. This procedure is called as your socket shield technique. This is called as a socket shield technique. Now, why do you do this procedure? In cases where you have a very thin gingival biotype, you have two types of gingiva. You have a thin gingiva biotype and a thick gingival biotype. So in a case where you have a thin gingival biotype, where you have a very thin buccal wall of the tooth which is present, where you think if you extract the tooth, once the buccal wall resorbs, your implant will lose the buccal wall. The most important portion for an implant to stay is your buccal wall. Okay. So buccal wall thinning or your thin gingival biotype. In such a case, you do something called as a socket shielding. You shield your socket with a part of your tooth itself. Now the tooth is the root is sectioned and it is thinned out. The pulpal remnants are removed. And if you see the last picture, it is a very thin wall of root which is placed there. Okay. Because of the periodontal ligament attached to that thin portion, there will be good blood supply to that area and the buccal wall remains intact. Also, it gives good retention to your implant to stay. Lesser bone resorption and better gingival aesthetics also. Because once the whole tooth is gone, in a thin biotype, there is a chance that later on, maybe after a few years, there is a small hue of your implant, the metallic portion of the implant, which is seen out through the gingiva. So to avoid that, it is called as socket shield technique. It is also called as PET, that is partial extraction therapy. All right, socket shield technique is also called as PET, partial extraction therapy or technique. Okay? For a completely edentulous mandible, the dentist decides to give an overdenture with mini implants. Okay. So what does he do? To achieve definitive prosthesis in complete healed of socket of less width and height, to achieve temporary prosthesis in completely healed socket, to achieve definitive prosthesis in recently extracted socket with sufficient height and width, or to achieve temporary prosthesis in recently extracted socket. It is to achieve temporary prosthesis in a completely healed socket. See, you cannot have a overdenture on mini implants for a very long period of time. It has to be a temporary process. It cannot retain for a very long period of time. Second thing is in its recently extracted socket, it will not stay. Mini implants do not osseointegrate. They only stay by retention. Okay. So if it is to give a temporary process, a newly extracted socket, then a regular denture would suffice till you give a final process. What is the function of crest module? What is a crest module in an implant? It is also called as the collar of your implant. Also called as your collar. Just a second, I'm just trying to see. Yes, it is a connection between the implant and the abutment. You're right. That collar is basically your connection between your implant surface and your prosthetic surface. Now, abutment again is the first stage of your prosthetic surface. So it is a connection between your implant and your abutment, the transition from your spiral to a smoother surface. It does not promote osseointegration. See, usually the crest module or your collar will be a very polished surface. Okay, it will be a polished collar, most cases. So it doesn't promote osseointegration anyway. Then allows gingival healing, not really, because it is going to be submerged into the bone. Okay, or at par with the bone. What is Nesbit prosthesis? Nesbit prosthesis means it is a unilateral single tooth partial denture. Okay, it is a unilateral single tooth partial denture, which is called as a Nesbit prosthesis. Which major connector is not bulky but provides good support? Anteroposterior bar, horseshoe-shaped bar, anteroposterior strap, or complete pallet? It is your anteroposterior bar. In a patient with periodontally compromised anterior, I think we already did this, the major choice of major connector is going to be a lingual bar. Sorry, it's a lingual plate. My bad. It's a lingual plate. Okay, the one we discussed earlier. Not a lingual bar, it's a lingual plate. This again, I think a couple of questions have come in between. Yeah. A cartwheel-like musculature that has role in border molding and neutral zone mechanism in complete denture. A cartwheel-like musculature that has role in border molding and neutral zone mechanism in a complete denture is your buccinator, masseter, and levator anguli oris. Buccinator, masseter, levator anguli oris. Okay. A hydroxyapatite coated implant preferred in comparison to titanium machine implant in an extraction site of upper left second molar, in which case except need for greater bone implant connection, bone implant contact, type 1 bone, freshly extracted extraction site, or newly grafted site. Hydroxyapatite coated implant can be given for greater BIC. It can be given in a freshly extracted site, can be given for a newly grafted site because it promotes more of osseointegration. But it is not much recommended to give in a type 1 bone. If it was a type 4 bone, yes, it was more advised, softer bone, okay? But not in a type 1 bone. A 39-year-old is with endodontically treated upper first molar. Crown height was less, so finish line is placed subgingival. What is the advantage of doing this? To place it on hard enamel, difficulty in assessing the restoration in recall visit, to assess it in aesthetic zone or all of the above. Sorry, to place it in aesthetic zone or all of the above. It is to place it on hard enamel. Doctor, you did mention to place it in aesthetic zone. I'd like you to come back to the question. It is an upper first molar. It is not even in the aesthetic area. Okay. In a molar tooth, you're not looking for aesthetics. You're looking for proper retention. Okay. Here you are going subgingivally in a tooth with a lesser crown for better retention and to place it on hard enamel. Okay. I hope that's clear. What is the disadvantage of a HTV over RTV? HTV means heat vulcanized and RTV is, it is rapid vulcanized. Poor color stability, opaque, low shelf life and low thermal stability. HTVs have lower shelf life than RTVs. They're basically used in maxillofacial prosthesis. Which of the following structures is not attached to the modulus? Quadratus labia inferioris, depressor anguli oris, zygomaticus major or zygomaticus minor. Always remember your zygomaticus minor is not connected to your modulus. Zygomaticus minor is not connected. So this is basically your modulus. Okay. Now what all is attached there? You have your buccinator, rhizorius, zygomaticus major, platysma, levator anguli oris, depressor anguli oris, depressor labia inferioris, and orbicularis oris. Now, from this, your levator labia superioris and mentalis comes out from your modulus also. Okay. Yeah, we already spoke about that. An edentulous patient, after receiving the denture, found it to be tight initially. But after some time, the denture gets loose. What could be the cause of this? Basal seat error? No. Because if there is an error in the basal seat, the denture would not be tight initially. So there is proper retention. Okay. So two things are ruled out. Basal seat error is gone and your impression error is gone. Okay. After some time, the denture is getting loose. So when you have an increased VD, okay, what happens is there is an premature contact of the tooth, which comes. When you have an increased VD, when you close slightly itself, the denture comes in contact and it tips off. That could be correlated with an occlusal error. So basically, the answer would be an occlusal error. All right. Why? Because if there is because of its tightness initially, that is because of the retention, it is not a basal seat error or an impression error. But occlusal error, it can be because an increased VD can also cause the same occlusal error to it. Okay. A pyre abutment was given for a patient for the condition which is shown in the image. Identify the correct statement. The key is present on the distal surface of the pyre abutment and the keyway on the mesial surface of the distal abutment. Key is present on the mesial surface of the distal abutment and keyway on the distal surface of the pyre abutment. The key is present on the mesial surface of the pyre abutment and keyway on the distal surface of the medial abutment. Key is present on the distal surface of the mesial abutment and keyway on the mesial surface of the pyre abutment. In a keyway, always remember your first prosthesis, that is the prosthesis which replaces the first edentulous space, will be fixed. Okay. So your key comes on your pyre abutment. So where? On the mesial or the distal? Very clearly, it is on the distal surface of the wire abutment. So you have your keyway on the distal surface of your wire abutment. Okay. And the key is always on the mesial surface of the prosthesis. That is the second prosthesis. Mesial surface of the second prosthesis. So this is how it will always come. All right. What is the advantage of a screw-retained implant prosthesis? Increased adhesion between the abutment and prosthesis? No. Accurate fit of the prosthesis? Yes, can be. Easy fabrication? Not at all. Can be accommodated in decreased interocclusal space. That is the answer. Now, when you have to choose a prosthesis for an implant, you choose it based on the space available. If you have a space which is lesser than like 5 millimeter or 4 millimeters, you always prefer to go for a screw retained prosthesis. More than 5 or 5 to 6 millimeters, it is always preferable to go for a cement retained prosthesis. Lesser interocclusal space. The loss of vertical dimension in a completely edentulous patient causes what changes in the mandible? What are the changes that are shown in the mandible with loss of vertical dimension? When you lose your teeth, okay, or when all the teeth are lost, the lower facial height will decrease. When the lower facial height will decrease, there is a sharper gonial angle which is formed. So what usually happens is the patient tends to bring the mandible forward so that anteriorly at least it can contact. So there is a forward movement of the mandible. This is what happens when there is a loss of vertical dimension. Okay, a displacement in the joint and a forward movement of the mandible. A 54-year-old patient provided with a positive history of myocardial infarction 3 months ago wants to replace his missing teeth with dentures. On examination, it was noticed that the patient has only 2 teeth which are periodontally compromised. What is the correct treatment plan? Wait for 3 months till interim prosthesis given, wait for 6 months and then proceed with the prosthesis, wait for 1 year and then proceed with prosthesis, extraction and prosthesis fabrication immediately. See, in this case, what you usually want to do is 3 months already down. Okay, he's come to you after 3 months. Second thing is, since he has had a history of myocardial infarction, there are all probabilities he will be put under blood thinners, anticoagulants, aspirin or clopid or whatever. He must be on that. Most of the cardiologists will never give a consent to stop this medication with such a recent history. Even till 6 months, they do not advise it. Okay. But once it is crossed about 6 months or 9 months, you can actually ask them for a consent. If it is aspirin, they can reduce the dosage, or if it is clopid, they will advise you to go ahead with the extraction and plan the prosthesis. Okay. So you wait for 6 months and then proceed with the prosthesis. Bilateral anteroposterior resection classified by Aramani. What is Aramani's classification? Anterior bilateral anteroposterior resection is class 4. This is the image of Aramani's classification of intraoral prosthesis for maxillectomy patients. Aramani's classification of intraoral prosthesis for maxillectomy patients is this. Okay. You have 6 classes. In that, the anteroposterior resection comes as class 4. What is the purpose of an implant analog? What is the purpose of an implant analog? Yes, an implant analog It replicates the implant in the cast. So once you make your impression with your impression coping, you place the implant analog. So when you pour the cast, this implant analog is in place of your implant in the cast. Okay, it has an opening just like your implant, and your prosthesis and attachments are done on top of that. It replicates the implant in the cast. It's very simple to correlate this. Analog. Analog means something which is very similar. Implant analog. So it replicates the implant in the cast. Transfer coping is also called as your impression coping, used for the impression making of the implant. It's called as transfer coping or an impression coping. Surgical placement, you use a stent. Okay. It's not an implant analog. You use a stent. What is the impression material of choice for a flabby ridge? Irreversible hydrocolloid, basically alginate, agar, addition silicone, or impression compound. See, when you're making an impression for your flabby ridge, you are going to use a mucostatic impression material. You're not going to use anything that is mucocompressive. Impression compound, addition silicone, both are extremely mucocompressive. So not the choice of material. Agar is also slightly mucocompressive, not much though, but you will need to press more to get a proper impression, which you cannot do with a flabby ridge. Irreversible hydrocolloid, in this, yes, it is an option. You can make an impression with alginate, okay? But if there was an option of impression plaster, that would be your material of choice for a flabby ridge, okay? Impression plaster, usually you make the impression, cut out the area where there is a flabby ridge, and you paint that area with impression plaster when you make the impression. So that is mucostatic impression that you can make for a flabby ridge. In a flabby ridge, you don't give a mucocompressive method. Why? Because once you compress the ridge, when the prosthesis comes, it is going to push it back. In the case of a unilateral distal extension partial denture, where will you place the indirect retainer? Yes, doctor, your answer is correct. Away from the fulcrum is correct. But here you have one more option, okay? On the canine. If you see, most of the unilateral distal extension cases, the away from the fulcrum point, it will always go and fall on the canine or the first premolar. All right. So in this case, the most ideal answer would be to place it on the canine. It is correct. Away from the fulcrum is correct. It is not that it's wrong. But on the fulcrum line, when you mark the perpendicular portion of it, it is mostly going to actually fall either on the canine or on the premolar. Okay, because it is a unilateral distal extension. Your canine or your premolar is where the fulcrum line will fall. Sorry, your indirect retainer should lie. So that will be on the canine. Which muscle participates in the buccinator mechanism? So buccinator mechanism basically starts from your fibers of the orbicularis oris, which goes and it joins with the fibers of the buccinator. From there, it goes up and the fibers of the superior constrictor muscle and then enters into the pharyngeal tubercle. Okay, fixes into the pharyngeal tubercle. So this is the path, how it goes. So you have your orbicularis oris muscle fibers, which comes and joins into your buccinator. From the buccinator into this, through the medial, the pterygomandibular raphe, it goes into the superior constrictor muscle and into the pharyngeal tubercle. That is your buccinator mechanism. So here the answer would be your superior constrictor. Okay, which of these muscles participates in? There are only three main muscles which participate in your buccinator mechanism: orbicularis oris, buccinator, and superior constrictor. One of the ways to alter anterior guidance is by altering the lingual surface of the upper anteriors, altering the incisal surface of the upper anteriors, altering the condylar guidance, or by altering the lingual surface of lower anterior. It is by altering the lingual surface of the upper anterior. See, when you have your upper tooth and your lower tooth, this is your cingulum area. What is anterior guidance? When you bring your mandible into protrusion, your lower anteriors glides along the cingulum area, glides like this, and then comes in contact with your central tip incisal edge. Now, the cingulum area is what determines the steepness of your cingulum area and your position of the central incisors. That is your overjet and overbite. These two are the things that will determine your anterior guidance mainly. So in that, how will you alter that guidance is by maybe reshaping your lingual surface or the cingulum area. So the guidance will decrease or increase as per needed. Altering the lingual surface of the upper anteriors. Patient with more upright central incisors than usual. The finding possible in this case is you have a more upright central incisor. What usually happens in that case? Your canine guidance is difficult to establish. Posterior crossbite, labiolingual more positive inclination, or posterior open bite. When you have a more upright central incisor, when you bring the tooth into protrusion, it is difficult to establish canine guidance because your central incisors will come in contact and interfere. Your incisors in this case will determine your guidance, not your canine. So we can never establish a canine guidance in such a case. What are the sounds which are affected due to faulty placement of incisors during teeth setting? Faulty placement of incisors. Incisors. What happens? Words such as F, B. Okay. So you have your labiodental sounds. Sounds which are affected are your labiodental sounds. That is words like F, B, where your lips will touch the incisor edge. A 70-year-old patient, denture wearer patient for 10 years is finding that his floor above the level of the bone crust and ulcers on lingual surface. What could be the reason? Increased vertical dimension of occlusion, bone resorption and prominent genial tubercle, frenum is not relieved. If the question was only the floor above the level of the bone crust, the answer could easily be bone resorption. But since the mention of ulcers on the lingual surface can actually show it could be a bone resorption and prominent genial tubercle. As your bone resorbs more, you have a more prominent genial tubercle. Now that is a cause that will impinge on your denture and cause a ulceration there. Functional cusp bevel is given at an angle of what with respect to the long axis of the tooth? At what degree is a functional cusp bevel given? It is given at 45-degree angle to the long axis of the tooth. So basically in tooth preparation, you have these principles. You have, of course, your principles of tooth preparation, preservation of tooth structure, preservation of marginal integrity, preservation of the periodontium, You have marginal structural durability, marginal integrity, resistance, and retention form. So these are your principles of tooth preparation. In that, in structural durability, first thing you have to do is your functional cusp bevel. Two reasons why it is given. One is for more bulk. Second is because in the functional cusp bevel is where most of the stress is taken. You don't want a sharper point and to take up more stress and crack later on. So you give a beveling in that area. Materials used for maxillofacial prosthesis that shows the most of discoloration is polyvinyl chloride. All these can be used as maxillofacial prosthesis materials, but in which polyvinyl chloride can actually show a lot of discoloration. The most common complaint of a patient with an auricular defect having implant retained prosthesis is low retention, low support, less stability, difficulty in hygiene maintenance. Yes, it is very difficult to maintain the hygiene. If you notice, you have 3 implants and 3 bars which are connected. But the space between the bars and the skin is very thin, onto which the auricular prosthesis is attached. Now you have good support, stability, and retention in this case, but difficulty to maintain hygiene. Okay, cleaning is very difficult in that area. After waxing, that is after a wax pattern is fabricated, a marginal discrepancy is noted. The wax added in the margins of wax pattern discrepancy. Wax is added in the margins of the wax pattern discrepancy. Now, the question is, can this be done or not? So it is done with naked eye, not done as wax gets distorted. It is not recommended or is recommended. This procedure is clearly recommended. Why? Because every time you take the wax pattern to check, there is a slight amount of marginal discrepancy. You place it back and you add onto the discrepancy area. That is a much recommended technique. What is die-core ceramic? Die-core ceramic, is it machinable, injectable, castable, or pressable? Always remember, die-core is a castable ceramic. Castable ceramic. The finish line for PFM crowns for supragingival margin. What is the finish line you give for a porcelain fused to metal crown for supragingival margins? Chamfer, shoulder, shoulder with bevel, or sloping shoulder? It is a shoulder with bevel. Shoulder with bevel. Yes. All of these are indications for porcelain laminate veneers, except discoloration, diastema, abrasion due to bruxism, or none of the above. Discoloration, yes, it is an indication. Diastema, of course, it is an indication. Abrasion, though, cannot be considered as an indication for veneers. Why? Because in abrasion, most of the enamel layer is gone. So in that case, you cannot take a risk of placing a laminate veneer because veneer bonds only well with your enamel. In the given picture, which of the following is an aesthetic choice? Modified ridge lap, ovate pontic, saddle, or conical? You can see it's a freshly extracted socket, not fully healed. Even a modified ridge lap can cause foot entrapment there. So ovate pontic will be your better option. A 54-year-old man or teacher by profession has Kennedy class 1 maxillary and completely edentulous lower arch. Kennedy's class 1 maxillary, completely edentulous lower arch. He is a teacher by profession. The maxillary anteriors have ceramic crowns with grade 1 mobility. What would be the treatment plan? When such case studies are given, no, you need to read it through very clearly. There is a reason why they have given his profession here. Okay. So if you see the first option, extraction of anteriors and complete denture in both arch, a teacher by profession, it will be so hard for him to extract and go back and then wait for it to heal and then give a complete denture. It will take such a long time for the procedure, whole process to take place. He's a teacher, his profession will be badly affected. Second thing, implant supported overdenture in lower arch and implants in the maxilla. Good option. Lower complete denture and upper RPD. Again, removable partial denture in the upper. The problem it can cause is that he can have difficulty in speech with his RPDs. Upper extraction and implant supported denture, both arch. Again, upper extraction, extracting the upper means affecting his profession at that certain point of time. So it is an implant supported overdenture in the lower arch and maxillary implants for the posteriors. A 24-year-old girl with missing 4.6, 4.7, 4.8 with supraerupted maxillary molars with only 3 millimeter interocclusal space. What would be the ideal treatment plan? Again, age is a factor. Okay. Why do you think the age is given in this case? Endodontic treatment and correction of occlusal plane of maxillary molars. Yes, it can be done. Extraction of upper molars and dyslexia RPD. Again, that is also an option. Lower removable RPD only. Great. It can be done. But considering her age, a 24-year-old girl, do you want to do so many RCTs and crowns in the upper? Not really. Do you want to extract all her posteriors upper? No. Will it be comfortable for a 24-year-old girl to be using a lower RPD especially for the rest of her life? Very difficult. So the best option is orthodontic intrusion of the molars and therefore followed by implants in the lower posteriors. Considering her age, that is the best option that can be done. That is why I said when you're reading, there is a reason why the profession or the age is mentioned for the patient. An interim removable partial denture is not used for what? To establish a new occlusal relationship, to establish vertical dimension, to condition remaining teeth in an edentulous ridge, or for an extended time. It cannot be used for an extended time. It is used to give a new occlusal relationship. That is, in case you want to increase the vertical dimension for a collapsed vertical dimension case, you give an interim denture with an increased height. To establish vertical dimension, yes. To condition remaining teeth and the edentulous ridge. That is, to get the teeth and the ridge accustomed to using a removable partial denture, you can use it. But not for a very long period of time. Which provides secondary retention in RPD. Secondary retention in RPD. Minor connector contact with the guide planes, occlusal rest, clasp, or intimate contact of the major connector with underlying tissues. Your clasp, occlusal rest, and your minor connectors are primary retention features in an RPD. They are not secondary retention features. Your secondary retention feature will be your intimate contact of your major connector with underlying tissues. Okay. The rest three are also retention features, but they are primary retentions. Which of this is true about a rest seat preparation? The sharp angles. There are sharp angles which are present. Floor is raised occlusally above the marginal ridge. Marginal ridge is lowered. Occlusal rest and minor connector angle is always lesser than 90 degree. Here you have your marginal ridge, which is slightly lowered. Okay. What is Kennedy's class 6? What is Kennedy's class 6? Edentulous area bounded anteriorly and posteriorly by natural teeth in which anterior abutment is not suitable for support. Edentulous area in which teeth adjacent to the space are capable of support. Unilateral edentulous area located posterior to the remaining natural teeth, which is class 3. A single but bilateral crossing the midline edentulous area located anterior to the remaining natural teeth. That is your class 4. We're talking about class 6. A single but bilateral edentulous area which crosses the midline is class 4 of Kennedy's classification. Class 6 is edentulous situation similar to class 3, but with this supporting tooth, that is anterior and posterior abutment tooth, are capable of support, whereas class 5 is where it is not capable of support. So this is class 5, edentulous areas bounded anteriorly and posteriorly by natural teeth, but in which the anterior abutment is not suitable for support. Class 6 is an edentulous situation in which the teeth adjacent to the space are capable of support of the required prosthesis. Okay. Class 5 and class 6 are basically modifications for class 3. Okay. Indirect retainer are situated as far from the fulcrum as possible, as close to the fulcrum line at the canine region, at the mesial marginal ridge of the premolars in class 1 case. Remember, we discussed a question where we spoke about a unilateral distal extension case and the indirect retainers comes far from the fulcrum or on the canine. That question was slightly more specific. They mentioned about a unilateral class 1 situation. Okay. Here it is a vague question. Where is an indirect retainer situated? In this case, you can always mention it as far from the fulcrum line as possible, because you don't know which situation it is. Is it a class 1, class 2, class 3, or class 4? You don't know that. So it is as far from the fulcrum line as possible. Okay. Yes. A patient with missing second premolar and first molar need rest preparation on the mesial side of the second molar. What would be the order of rest preparation with proximal preparation? No specific order, prepared simultaneously. Rest preparation must follow proximal preparation. Rest preparation must precede proximal preparation. Always your rest preparation must follow proximal preparation. Your proximal preparation is basically placement of your guide plane. Okay. Place the guide plane first, remove the undercut, and then you do the rest preparation. Okay. First, the proximal preparation is done, then the rest seat is prepared. So the distance of your rest and the depth of your rest will actually vary in that case. What is the distance between the maxillary major connector and your gingival margin? Maxillary major connector and your gingival margin. Basically, they're meaning about the borders of the major connector. Okay, that is 6 millimeters. Edentulous areas other than those determining the classification are referred to as modification areas. Applegate's rules. Yes, that is your Applegate's rules. They are called as modification areas. That is modifications or modification areas. The purpose of anteroposterior tilt of your cast during surveying is to provide relative parallelism between the proximal tooth surfaces, indicate greatest available support for RPD, provide suitable reciprocation for retentive arms, or all of the above. It is to provide relative parallelism between the proximal tooth surfaces. Okay. Anteroposterior tilt is to provide slight amount of parallelism. The combination clasps in bilateral edentulous patients engages distobuccal undercut, can be adjusted by the patients, more aesthetic than circumferential clasp, and minimal coverage of tooth surface. Which of this will be correct? A and C, B, C and D, B and D, A, C and D. Combination clasp. B, C and D. It can be easily adjusted by the patient. Combination clasp will have a wrought wire clasp and your cast clasp. Both will be present. On the buccal surface will be your wrought wire clasp. So it is much more aesthetic than your circumferential clasp. Okay. It can be adjusted by the patient because unlike your cast clasp, this is more flexible, right? And minimum coverage of the tooth surface. All three are correct for a combination clasp. Okay. So that's it. So this is an overview of how most of the previous year's questions have been asked. You know, I've shortlisted most of the important questions which are repeatedly asked, and also most common type of questions that has been asked. All right. So in case you have any doubts, please feel free to contact us in the group. We'll be available to help you with it. In case you have any doubts, you can clarify. You can just tag us in the group and clarify. All right. With that, I'll end the class. Okay. Thank you so much. Good night. Thank you.